Okay, so it's now 4:01, and my name is Stefan Johansson, and on behalf of everyone in the 99 NICU team, I would like to start welcoming you all to this first webinar in our series of Neovation webinar series, where we will be taking a look at new innovations shaping the future of neonatal care. These webinars are designed to bring you new insights and learnings from innovations and technologies in neonatology. We do this in partnerships with smaller startup companies throughout Europe and with guest speakers. The format of the webinar is that the two partner companies will have a short presentation about what they do, and then we will be shared two 15-minute guest lectures. And today we would like to welcome Concord Neonatal and Arne, both companies based in the Netherlands. And I would also like to thank you for supporting this webinar. We're also delighted to have Professor Rüdiger and Dr. Tim Antonius as our guest speakers. So, short introduction to our guest speakers. Professor Rüdiger is a professor of neonatology and pediatric intensive care medicine at the University Hospital Carl Gustav Carus in Dresden. And I think many of you know Professor Rüdiger from the yearly Delivery Room Management Symposium. Professor Rüdiger has implemented the Concord birth flow in his department since 2021, and he's going to talk to us about why and how we are to perform physiological-based cord clamping. Our second speaker is Dr. Tim Antonius. He's a senior consultant in neonatal intensive care, ECMO specialist, and simulation expert, and neonatal life support course director. He is the inventor of the so-called parallel ECMO simulator and the Arne decision support device. Arne stands for augmented reality in neonatology. Dr. Tim Antonius will be sharing about how we can use technology to help a baby to get the best start possible. After we've had the two guest presentations, please join us for a joint question and answer and discussion session. Use the chat. You find it in the lower panel of the Zoom window, and we will be moderating all the questions coming in. Thank you so much. Now I would like to hand over to Concord Neonatal for your first short presentation. Thank you.
Thank you very much, Stefan, for this opportunity for us to present. Welcome everyone. My name is Rianne, and I am the co-founder and CEO of Concord Neonatal. Concord Neonatal was founded as a spin-off of Leiden University Medical Center, and the great work that is being done by Professor Arjan de Pas and his team, specifically on the topic of umbilical cord management after birth. And it's our mission for all babies to have a shock-free birth and for them to benefit from the blood of the placenta until their lungs are aerated and they're fully stable. And we call this, and the solution that we offer, the Concord birth flow, which enables the neonatal caregivers to provide all the care that some babies require and support immediately after birth, but keeping the baby very close to mom with their umbilical cord still connected until they're breathing on their own and fully stable. And a key element of the Concord birth flow is our Concord birth trolley. It's a mobile trolley that you can position in your delivery room or your operating room with a cradle that can be positioned very closely above the mother and where the baby can be placed. And the trolley has a pole to attach all kinds of medical equipment that you would like to use and you require to provide full resuscitation or stabilization. And it also includes a radiant warmer. You can perform the Concord birth flow in your delivery room or in your operating room, where obstetric caregivers and the neonatal caregivers work closely together to provide the best care for the baby and for the mother. In the meantime, 40 hospitals are part of our Concord community. The University Hospital in Dresden is already part of our community for 2 years, and Professor Rüdiger will tell you all about why to perform the Concord birth flow and how in his talk. And if after his talk you're interested to know more, I can advise you to sign up for one of our Concord talks. This is a series of webinars. We have many already available on scientific and all kinds of practical topics regarding physiological-based cord clamping, and there will be many more to come. So I invite you to join us to provide a shock-free birth flow for every baby. And if you would like to discuss with us, send us an email through join@concordneonatal.com. Thank you very much.
Thank you so much, Rihanna, for your presentation. And I would now like to give the word to Rob from Arne, please.
So sorry, I had to unmute myself. So share the screen. So, well, what's Arne? And we are more software-based company, and Arne stands for augmented reality in neonatology. This is how we started. And basically, what was the problem we are addressing? Addressing the problem that 10% of all births, as you probably know better than I, will need assistance or will need extra care outside the regular birth care. And we also know that we have around 15 minutes to get the baby stabilized and ready to go. Those first 15 minutes are just as in adult reanimation. They are crucial and critical for the further survival of the baby. My name is Rob de Vroet, and I'm the CEO and founder of Arne. Arne is a development from the Radboud University in Nijmegen. Dr. Tim Antonius is the one who invented this, and he started to work with the HoloLens option, which we fully refurbished and rewrote the software into a medical device, which carries all functions in it. So you will get physician assist software, which will follow the NLS protocol very closely and advises you what to do when. It will show the critical parameters from the equipment already available. So heart rate, oxygen saturation, breathing frequency, and when available, temperature. But it will also help you in the medication part of the treatment, next to what you need to do, how you can do this. So it's guiding you through those first critical minutes. Currently, we think we have 50% less mistakes being made, what we saw through an initial study performed by Tim Antonius and his team. And we also saw that there was an opportunity to be 25% faster in the total treatment time, which is also critical because the sooner you get the baby stabilized, the better the outcome will be. Okay, so for me, this is what we are currently doing. The device is just ready. We are going to launch it on the market at this, actually at this time. So if you want more information, visit us at arne.health. That's our website. It's very easy to remember. Remember arne.health. And if you want more information, obviously we are very well available for you.
Thank you so much, Rob, for your interesting presentation. And now I would like to give the word to our first guest speaker, Professor Rüdiger from Dresden. And it will be very interesting to hear your views on physiological-based cord clamping. So whenever you're ready for screen sharing, please unmute and start.
So thank you very much for the invitation to be one of the first guest speakers of your series of lectures. It's a great honor. And as you said, I'm going to talk about physiological cord clamping, just a few information concerning potential conflict of interest. I think there's no financial potential conflict of interest. I'm a member of the German Foundation for Sick Newborn. We have several information on these for the German speakers can look at, and I'm a member of the ILCOR Neonatal Task Force and ERC, but both are not part of recommendations, and I got some honorarium. And so, but no honorarium for today. Looking back on delivery room management, so there's a seminal paper of Virginia Apgar, and she said there's a lot of stuff which is done in the delivery room which has no evidence yet. And there's another seminal paper which is from Neil Marlowe, and he talks about the elephant in the delivery room. And if you look back what we did in the delivery room, it's a very aggressive approach. And I think the next step is really necessary to have a more physiological approach. And that's the reason why I give this presentation. First of all, I want to introduce you why I think it's important, looking about the physiology of postnatal adaptation. And then I will give some information how we introduced these devices in our institution. And looking back concerning the physiology, it's important to remember that the lung of the fetus is filled with liquid. There's a lot of liquid production in the lung, and so that means the airways after or during pregnancy of the fetus is filled with quite a lot of liquid, up to 50 ml per kilogram body weight. And if you look at the airways in the newborn, it's just about 30 ml of air which is in the airways. That means it's within a few seconds or a few minutes, this liquid has to be removed after delivery and has to be replaced by air. And that's a very, fortunately, most of the babies achieve these within a few seconds, but a few babies, like about 10% or so, they need some support. And so this support is aiming to remove liquid and entering air. And removal of liquid is done into the interstitial space. If you see here, the alveoli with liquid filled, and if you have a successful resuscitation or successful adaptation, you see a lot of liquid is entering the interstitial space. It's not removed outside of the body, but into the interstitial space. And there are there are big forces which are working in these babies. You see in these X-ray done during the first breath, you see a lot of pressure, the chest is compressed. And so there's a lot of force needed and high pressures are needed. If you look at some measurements of the pressure, it's up to 60 centimeters of water, which is the driving pressure into the airways of the air. And at the end of inspiration, you have a pressure of up to 30 centimeters of water. And all these processes done in a healthy baby without any support. But in some babies, you need some support. Usually you have these very nice small inflations of the baby, and you have a certain time after delivery which is needed just to get the physiological breathing movement and these nice sustainment of FRC of air in the airways. And if this is not achieved, you need some interventions. You need, for instance, PEEP administration, sustained inflation, we can discuss it. And so you need these PEEP and so on. That means you need some neonatologist. But usually that's done, the baby is delivered, it's cord is clamped, and then you start with PEEP. But during the last decade, there was a lot of attention on not only on the ventilatory parameters, but also on the side of the hemodynamics. And if you look at the hemodynamics, it's very important to know what happens with the hemodynamics. That means if you start cord clamping, if you have cord clamping, then you have no flow from the lower venous or from the right atrium. You don't have any flow from the umbilical cord, and that means you have a decrease in right ventricular output. That means in the pulmonary artery, you have less flow. And the next step is if you start ventilation, the lungs are open. And if the lungs are open, you have an increase in pulmonary perfusion due to start of ventilation. And that means if you have first cord clamping, there is no effect on pulmonary perfusion, But if you then have ventilation, you have a high need of pulmonary perfusion. And that means there is a lack of perfusion. And if you look at the duct, you have over the duct, you have a right to left shunting. And then after starting cord clamping, then you have decrease in right to left shunting. But then after starting ventilation, you have a high need for pulmonary perfusion. That means you start to have a left to right shunting. And these left to right shunting, if perfusion or if lung ventilation starts after cord clamping, is causing some trouble in systemic perfusion. And you see these, if you have immediate cord clamping, then you have some really severe changes in carotid blood flow, which can have severe impact on very preterm babies. And these very preterm babies are very prone to cerebral hemorrhage. And so there's a high risk of the situation we are doing. And if you have these physiological-based cord clamping, then you have ventilation initiated prior to cord clamping. And that means you have ventilation without any severe changes. And that means after cord clamping, you don't have any changes in carotid artery and blood flow. And that could be protective for preterm babies. And so looking at the physiology, it makes sense, like nature is doing, to start first breathing and then to do cord clamping. But in current setting, that's not always possible because of C-section, for instance, and then the baby is brought, you start to ventilate after the cord is clamped. So that was the reason why we decided to start with a device which supports a physiological-based cord clamping. And then we had the device, and now we asked ourselves what to do, how to introduce this one into routine care. And the most important step is, first of all, you have to test every single step with everybody. That means you have to include all specialties, nurses in the operating theater, anesthesiology, obstetrics, gynecology, neonatology. And so we started like here, it's just a dry team, which is our obstetrician. There was an obstetrician, she served as a mother. We had a baby, we had a neonatologist, we had the anesthetist, and we tried every position and we tried everything. What happens if we start anesthesia? What happens if we start the C-section? What is the best situation for the surgeons to place the trolley? What is the best situation in case of an emergency? How to handle this one? What has to be looked for, sterility, and so on? That's very important to have all these single steps discussed with the team. And so we had these sessions for 3 times because we needed some adaptation of the equipment, some adaptation of the surrounding of the procedure during C-section and so on. And after that, we tried it again. What happens if we have this removal of the baby? How can we enter our usual place for resuscitation? What happens if there's an emergency with the baby, and so on? That's very important to discuss everything. And thereafter, we had we tried the entire sequence of events. That means what happens prior to C-section, how to enter the device into the operating theater, what happens during C-sections, how can we continue? We wrote an SOP, standard operating procedure, and we started with agreeing on an indication, on a common indication. What are the babies we want to treat with a Concorde? And so in our institution, we decided that delivery room management with physiological-based cord clamping should be performed in all preterm births with a gestational age between 26 and 33 weeks of gestation. We decided it can also be performed in babies which are lower than 26 weeks or older than 34 weeks. It can be performed if there is a malformation which could benefit from these physiological-based cord clamping. And we defined also some contraindications for physiological-based cord clamping. And there was placental abruption, placenta previa, an emergency C-section, prenatally known congenital diaphragmatic hernia or gastroschisis, or even if the obstetrical or neonatal team has no experience in doing physiological-based cord clamping. And then we had the next thing that we decided what is, how can we prepare for this one? That means for every C-section which uses physiological-based cord clamping, we need an indication which is done by neonatologists and obstetricians. And then the obstetricians go to the mother and explain everything, what happens with the baby, and they inform the neonatologist if the anesthesia starts. And then the nurses in operating theater, we have to find what they are going to do. They have to connect the equipment and so on. And we also have to find what neonatology is responsible for. So that means every part of the team knows what their responsibility is, and every part knows what the other responsibilities are. And so we have this device, and we said, in our institution, we added monitoring, we added CPAP and ventilation devices, suctioning devices was added, and we also added some small gas tanks just in case of a stop of systemic gas flow. We added the heating, we have this device, and so we decided in our operating theater, these are the anesthetists in front of the mother. We have the first the surgeon, second surgeon obstetrician, and we are entering via the legs of the mother because the second surgeon is here, and so we are entering from this device. It's in our institution the best way to enter. There are other institutions which enter from this side or from the other side, but in our institution that was the most practical aspect. And that means we have this procedure, we place everything sterile. The neonatologist is taking care everything above the umbilical cord with sterile, sterile hands and so on. We are placing the monitoring on the wrist, and so we have this support until the baby is crying or the baby is breathing. Then we can move with the device to the usual delivery room care room. And we decided if one of the following criteria is achieved, we stop or we do cord clamping. That means heart rate is above 100, stable above 100, saturation is above 85%, FiO2 is less than 40%, and the baby is breathing. Then we can do the cord clamping. And if there's any sign of risk for mother or baby, then we can do an early cord clamping. And we are not looking at the other steps of delivery room management are done, like surfactant therapy are done in the separate room after cord clamping. And oxytocin for the mother is given after cord clamping. And then we move to toward the next room, and we stop with the parents. That's an important aspect, stopping with the parents with the baby so they can touch the baby, can see the baby. And that's one of the most important aspects besides the physiology, that there's a chance of early contact with mother and baby. And then the baby is in our institution is taken from the table, placed on the scale, and then put the resuscitation table, the incubator. And we use the same sensor and the same mask on the resuscitation table to do intubation or to sort of give surfactant and so on. And that's the best aspect for me is this one. That was a very first baby, and you see the mother is laughing and is touching the baby. The daddy is happy about it as well. And so that's a very, very important aspect, because I think that's the very early step of getting attached to the baby, very important aspect for future bonding and parent-child interaction. And that's a very good aspect, very important aspect. If you want to see the approach, we have a video. You can see it on our homepage. And there are several steps of our approach on YouTube or on the homepage. And if you want to learn more, you can come to the symposium to Dresden. Just write me an email or look on the homepage. Then you can learn more about it and can even train these management on the Concorde. So that was a very short summary why I think it's an important aspect to have these Concorde or to have these physiology-based cord clamping.
Thank you so much, Professor Rüdiger, for this very interesting discussion. I would like to remind all the attendees again that you can post questions in the chat, which you find at the lower end of the window. And now I would like to introduce Dr. Tim Antonius to share about how technology can help babies to get the best start possible. Thank you. Please.
I think you can understand me. Can someone not, please? Yeah, okay. Thank you for the invitation on this nice initiative. And in 15 minutes, I'm trying to take you to some parts of technology helping a baby to get the best start possible. And in contrary to my predecessor, I do have some, I do have some conflicts of interest. Like in the introduction talk, I was the inventor of ARNI, so that's a conflict of interest. And I do have some other products on the market which you can show over there, which I don't talk about in this talk. I would really recommend you if you want to know something about the delivery room of tomorrow. That's a very nice paper actually published a few months ago in pediatric research on Natalie Beatty on somewhat of the emerging technologies, and I want to take you a very short summary of this nice article. It's called the delayed cord clamping. No, okay, that's what we heard about. It seems like a good idea. What our previous speaker talked about. Then we had some term. I thought that's not really new, but maybe there's some new techniques in how to get the best possible temperature. Respiratory function monitoring is actually coming. The devices are coming available. They're available for a long time already, but now it's also commercially available. And video laryngoscopy is maybe, especially for the very small ones, are coming available in the last few years. And augmented reality, that's what I want to talk about in a few minutes. And the clinical decision support, that's also one of the maybe emerging technologies. And then we have a video recording, which is done in some centers, and with, of course, with very good video debriefing, and some human factor training, which we do already for quite some time. There's some other techniques in trying to get breathing and aeration of the lung, maybe to see that in a better way, and the telemedicine and remote consult. Those are the main factors which are actually in that article, and I really recommend you to read this. Contactless monitoring is also some areas which are explored and are devices coming available now. I looked at our Concorde. This is actually our Concorde, and I thought, okay, delayed cord clamping, we're doing thermal regulations, we're doing respiratory function monitor. We have the MobiVent ventilator of respiratory function monitoring. We have the ARNI as a decision support tool. We can do some video recording. So this is actually in our setup already. Quite a lot of techniques are implemented. This is our actually setup. We do our on a Concorde or in an incubator. That's where the baby is stabilized, and we have some actual devices there. And you can see the HoloLens over there. That's what I'm going to talk about mainly in the next few minutes. So for the technology, look at the paper. There are some really nice ideas on how to use technology. And I want to talk about how can you actually use augmented reality in clinical practice, and is there a way to use clinical decision support, and why should we do that? decision support tools for neonatal resuscitation, and I'd like to give you some so it's a small background. The main, and I think that the second quote of Robert Hayward is the best one. The clinical decision support tools, where they help you to link your observation with knowledge, and can you help to perform better in making the right choices. So I like to call it physician support instead of decision support. And I know a delivery room team is not only physician, but it sounds better from decision to physician. The first question you have to ask is, do we need support? So we have some evidence that standardized formal resuscitation training programs reduce that early neonatal and 28-day mortality. We don't know much about morbidity, but we also know that a bit. It's in a Cochrane review in 2015. So it might be a good idea to adhere to those standards as posed by the ERC or maybe the American Heart Association. And we had a lot of progress in doing that and in training people about better. But still, one of my colleagues published about that is about half of the neonatal resuscitations, the team deviated from those guidelines. And then the more complex those resuscitations or the stabilization were, the poorer the adherence to those guidelines was. So it might be we could use some support in those more difficult situations, maybe. How can we do that? We can use simulation quite a lot, and we use a lot of human factors, educational techniques and crew resource management techniques to improve that. It's always better to train much more frequent, and maybe we can use some clinical decision support tools to help those delivery room teams. That's my main topic, of course. But we already have a lot of them: paper posters and paper cues and all kind of small handheld devices which help residents and maybe other caregivers to help to remember what to do. But we know the posters and the paper cues have no effect on the performance. So what's the goal of our decision support tools are actually to reduce that cognitive load of the following the algorithm, and that's one of the main goals of our clinical decision support tools. So we can actually concentrate on the tasks we have to do, but because the tasks are not really easy sometimes, airway management is not always easy. Doing a good having a good workflow on the Concorde is not always easy. So to reduce that cognitive load might help. There are multiple studies actually showing that works, but they're all in simulated resuscitation settings. Our colleagues in Stanford actually had already thought about this, and in simulation settings, they had a decision support tool, published it in Resuscitation in 2015, where they had the kind of iPad and then looked at whether that works. And yeah, that works. Fewer deviations from the NRP guideline. So that also in the neonatal simulated resuscitation seemed to work, but that device had no integration of vital parameters, no dynamic or nor adaptive algorithms. Structured resuscitation program does improve outcome. Poor adherence to guideline remains. Why don't we do that well? We don't know really that well. So what we wanted to achieve is with our clinical decision support tools and how to improve guideline adherence. That may be the easiest task to influence, and that might have a good effect on our outcomes. We don't know for sure, but that's the best we have now. So we thought about wearable devices like mixed reality or devices like the HoloLens. Just to be sure we're on the same page. Augmented reality actually overlays some digital information on real-world elements, and mixed reality helps us. We can actually interact and manipulate those physical and virtual items. So we started out with connecting the vitals and so the monitored vitals from the baby to our tool, to our decision support tool, which was running on an augmented reality device. And this, and the most easy one is the Microsoft HoloLens. So this is the device, you all know this. This is actually the lab. This is my son. He can use it. It looks much better in our delivery room. And this is what you can see. So the interface actually showed you the heart rate, the O2 sats, respiratory rate, and the temperature. It got you some main advice, then some sub-advice, your medications on the right, and on the left, some other information. So we thought that might be a good idea to do this way. So how does this look? That's floating above the baby, this holograms, and you can actually, the HoloLens talks to you about what will be your next step. This is moving actually. So this is filmed through the HoloLens, and that is floating above the baby. So you can do your thing and look at that at the holograms. For time purposes, I don't show you the whole video, but this is a way of how to use clinical support using augmented reality. And we did some study with this. And we published this last year in the Simulation in Healthcare, where we simulated setting, and we did try to look. We scored the pediatrician using the HoloLens as a decision support tool, and it actually did quite well. This is Kishan, which is a mobile setup, went to all the hospitals in the neighborhood, and tried to and did the study. So. I won't take you to the whole study, but what we saw is that there were less, that the total points scored, so the adherence to guideline score was better. So people performed better. They forgot less things to do. They adhered better to the guidelines using the HoloLens compared to in subjects working from memory alone. And they weren't slowed down by it. There was one big problem. So the technical feasibility of this was okay. So we could reliably connect the HoloLens to monitoring systems like the Philips or the Massimo monitoring systems, and we could integrate them into resuscitation guideline. The holograms also were able to show that important clinical information, and the caregivers could work with the HoloLens after a short introduction. It was definitely not comfortable to wear, and the devices are actually quite large still. The visibility of the HoloLens of the holograms is still a problem. Even in the next generation devices, it's still a kind of letterbox frame where you're looking at. Battery life and booting times are maybe not sufficient for clinical practice, and the voice recognition is actually in the clinical practice in the delivery room not good enough. But one of the most important things is that the team communication is lost. The holograms are only visible for the wearer of the device. So the nurses or the residents you not wearing the device could not see what the leader was seeing. And that was one of the main problems. And it is not medical grade technology. So the voice recognition is not there yet. The booting time is not there yet. So it's really difficult to get this approved as a medical device. So there's also an article on augmented reality isn't quite there yet. That's not only in medicine, but for the clinical practice in an approved medical device, it's not quite there yet. So we thought, okay, can we do this? We see that clinical decision support might be a good idea, but can we port it to a system which uses the same integration with medical with the vital parameters, but still is able to have medical grade technology, and the team communication is not lost. So we ported it to a device. It's a device which is actually you can use on your setup. It's a small tablet, and I can show you. I have to share my screen, a different screen. What will happen? So this is our clinical device tool, where you can see you can start a new session. This one is in training mode now. You get the vital parameters up at the bottom, and you can start a new session. You start with telling the device, okay, what kind of baby do you expect to have? Now maybe we select now, we can select a small one. You have some special circumstances. The device will actually give you some indication of the weight, and you can start. And you can't hear it, but the device will talk to you and takes you through the neonatal life support algorithm. So possibly delay clamping of the cord, place the baby in the bag, and there's some photographs in there on how to do that. There's some information on the possible drugs you need further up, and there's a next step. And you can actually go to the next step, and it will be auto-detected. So there's an auto-detected here that the baby is not breathing. It's not allowed by regulation to automatically proceed. So you have to confirm this and go to the next step. And this clinical support tool can take you through a lot of different steps of the neonatal life support algorithm. And it also, one of the feedback we got from pediatrician users is that there's always a next step. So that next step is always there. There's always might be another idea, maybe do this, maybe do that. So that clinical decision support tool can take you to the whole stabilization phase using the neonatal life support guideline as a guide. It takes away the cognitive load of memorizing what the next step will be in the neonatal life support guideline. So you can concentrate on the tasks. So we know clinical decision support are able to improve neonatal life support guideline adherence. We know mixed reality is definitely promising, but it's still not medical grade technology. We have to think about how to use that, and we're actually trying to find new ways of using that mixed reality. But for now, that's not medical grade technology yet. In future, that those devices will be much better, and maybe we can find some ways in using it, because I think that hands-free experience, that projection of holograms above the baby is actually really, can be really helpful. But at this stage, not augmented reality, clinical decision support, yes, but maybe using other tools. That's my talk for now. 16 minutes, so 1 minute over to you.
Thank you so much, Dr. Antonius. Very thought-provoking presentation, I think. It's when I heard both of you, I was feeling I'm still in the delivery or resuscitation room of the 20th century. So now let's have a look in the Q&A session window and see what comes up. Maybe we can ask direct a question to you first, Tim. One question was about the hologram on the glasses and how they interfere with procedures you do, umbilical lines and intubation, or how is the feeling when you wear those glasses?
That's a very good question. Actually, the lens is a see-through lens, but they're not that good to see through that you can perform your tasks quite well. So you have to look underneath them most of the time. And that's actually that's also a downside to these devices. And in future that will be better, but it will hinder you. So the best way, actually the best way that HoloLens worked was using the leader, having the HoloLens, and someone else with the real skills, doing the intubation or the umbilical cord cannulation or whatever. So yes, that is a problem still.
There was another question, and I think this is a question for both of you, because, you know, in the resuscitation scene, it's quite common that it's you need to connect and disconnect probes because they don't get stuck, ECG electrodes, and the saturation monitor needs to go on and off a few times sometimes. And both with the RNA technology, but also in the delayed cord clamping setting, is this posing some special challenge in your different contexts, do you think? Because you need the data to take new decisions, either through augmented reality or when you are to do the cord clamping itself as such. I mean,
shall I answer this first?
Please,
Dr. Rüdiger. Yeah.
Yeah.
Yes, but actually the neonatal life support algorithm is actually about, is the baby breathing most of the time and what's the heart rate? So yes, that decision support tool actually uses that vital parameters, but it also, if it's not actually detecting some heart rate or getting some pulse oximeter signals, it actually asks you, okay, assess the heart rate. What is the heart rate? So we have, yes, that is a problem of connecting and disconnecting, but essentially you listen for, you can also listen for the heart rate if you don't have a signal, and the device will actually adapt to that. But no, that's my main answer, I think.
I think that's a good point. So we have a lot of technique, but we should not forget to use our senses as well, because technique can fail and so on. Yeah.
And Professor Rüdiger, what for how long are you keeping the cord intact? I mean, you have your criteria for cutting the cord, but if it's a more complicated situation.
The main goal is that ventilation is initiated. If you do have a sufficient ventilation, then you can cut the cord because there is no benefit. It's not only about the blood transfusion, which is considered, but also the other side. You have a low, you have also in the arterial part, you have a low pressure system, and this part is also very important in keeping the cord intact. But as soon as ventilation has started, pulmonary perfusion has started, then it's fine. You can clamp the cord. And if the ventilation does not start until 10 minutes, then there is no benefit at all.
Another thing related to the cord clamping, as I understood, in emergency cesareans, you prefer not to do the delayed or the physiological-based cord clamping. But I was just thinking, wouldn't it be the case that it could be even more beneficial to do physiological or later cord clamping in those more complicated deliveries?
That's a very good point, but there's also a caveat. That means all I was suggesting is currently just physiology-based. It means there's no good data which you can recommend, so we cannot recommend it now. So the final trial for preterm babies is almost finished, and we will get the data soon, and then we can recommend it. So currently there's no recommendation to do it. And as soon as we get more experience with preterm, stable preterm babies, and as soon as we get more data concerning congenital diaphragmatic hernia and so on, we will get more data on resuscitated babies as well. And then we can answer that question. Currently, there is no recommendation to use it at all.
There is one more question to you, Professor Rüdiger, before we go back to Dr. Antonius. One about the skin-to-skin contact between the mother and the infant and the technology that is around. And one related question early in the chat was also about the temperature control. Could you elaborate a little bit on the mother-infant interaction and temperature control and so on?
Yeah, concerning temperature control, you have to be aware concerning your situation. So we increase temperature in the delivery room, in the operating theater, we use plastic wrapping and so on.
Right.
You have to check that the temperature is correct. And skin to skin is a very good approach, but actually nobody I'm aware of is using immediate skin to skin contact in very preterm babies. And so that's not the option yet, to use it as skin-to-skin contact in the C-section room. But it's a very good chance to have very early eye contact, have the baby stabilized, and after having the baby stabilized, should have skin-to-skin contact even in the delivery room. That's a very important aspect.
Thank you. So, Dr. Antonius, there is one question for you. about what kind of data you present on the...
Yes, I would really like to give them some more maybe AI generated advice, but we have to be really careful what to display on those holograms, because they're actually looking at very a fraction of what you're displaying.
Yeah.
So interface design is one of the main problems of these kinds of devices, I think.
So there is a related question about the RNA, about vital signs, as long as the monitor is not yet fixed. I'm not sure how to interpret. Do you understand the question, Dr. Antonius?
Yeah, sure. Yeah. Yeah, if there's no monitor data, the device will just ask you, is the baby breathing?
Okay.
And it'll ask you, is the heart rate above or 60 or...
Okay.
And it does that. And if it has a detection, if it has a signal, then it suggests what to do, but you still have to confirm it. And that's due to regulations, medical device regulations.
Okay. So there's one question about deterioration when the baby is still corded to the mother. For you, Professor Rüdiger, what do you do if the baby's condition is deteriorating when on the Concorde?
Actually, you should improve your management, and then you can ask him to get his suggestions.
Yes.
No, I mean, if there's a real problem with the situation because you cannot handle it, you have to cut the cord and go to your resuscitation table.
Yeah.
But actually, it's much better to have a resuscitation or improve the situation of the baby if the baby is still on cord.
Yes, of course. So I was thinking about one thing relating to the recording, video recording. Do you somehow consider like GDPR or patient integrity? Do you like formalize something around video recording in your units? Do the parents need to give consent to video recording? Because we have been discussing this ourselves, how to audit ourselves through video recordings. How do you do that in your units?
In our unit, we aren't there yet for video recording. In Leiden, in University in Leiden, they record the delivery room management for years now, but we're still having trouble, like you stated, in getting maybe some legal issues on, is that recording part of the electronic patient file, or is this recording just for review? How do I get permission? Who's on that? Do we need permission for everyone in the room, or do I just film the baby? So for training purposes, we always video. For the simulation, we always video, but the video recording in the real, I think it's really valuable actually to do that, but there's still some hurdles we didn't cross yet.
So we are using video recording for every preterm baby in our institution, and we got a general permission. We don't have to ask the parents because it's a quality improvement measure. We have just to ask the parents if we want to use the video for teaching, to give somewhere else for teaching or for a scientific analysis, and we need permission.
Okay.
And there's a question concerning data in context of developed nations. There is actually, again, there is no data of benefit yet. There are two studies which show there's no data of benefit yet, either for developed or developing countries.
So data to come. If we are looking into the future scope, 100 years from now, how do you think the resuscitation delivery suite context will look like with technology and team, and what do you envision?
I think one of the most important things I learned is what Professor Rüdiger in the start of his talk said, that we might be more gentle, might be more, take your time. It takes time to do that transition correctly. And if we use technology like decision support and maybe tools to better document that the baby is actually breathing on its own and there's air inside the lungs, that might help us a bit in preventing us doing things which are not that beneficial, but maybe to help us to be somewhat more gentle in these kinds of things. I think, yeah, technology can help us to lose that cognitive load, to not jump on that baby, to make sure you do intervention only when needed. So that might be a benefit.
And just one addition, be careful what you are doing, or be aware of what you are doing. So that means like video recording or anything, giving feedback, or have a critical look what you are doing, whether it's necessary and whether it's effective.
I just I don't know if you have looked into this artificial intelligence chatbot, but I just have a feeling that we will be having tools available that we yet cannot imagine. Maybe we will have videotaping, and we will be guided from a voice, interpreting what the camera is seeing and helping us to do the right things at the right time. Who knows? But I just sense there will be a lot of paradigm shifts ahead of us. But time will tell, and we will not be there in 100 years to see ourselves. But your son, Dr. Antonius. Okay, we are reaching the time, 5 o'clock, and I would just like to close this first webinar event in this Neovation webinar series, and thanking the partnering companies Concord Neonatal and Arne, and of course also thank our speakers, Professor Rüdiger and Dr. Tim Antonius, for sharing their knowledge and experience and innovative ways of working in the management of newborn infants. And last but not least, I would also like to thank all the participants. It has been almost 100 people in this webinar, which is fantastic, I think. And we look forward to meet up next time, which will be on Valentine's Day, the 14th of February. And that webinar will have a theme around ventilatory support of term and preterm babies. So thank you so much, and see you next time.